Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds, premier education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and affiliate partner, Medela, the Science of Care. I'm Eric Lim, and this week is a great delight for me to present Professor Amanda Tufman from the University of Munich to talk to us about BRAF-targeted therapies in non-small cell lung cancer. Thank you, Amanda. Over to you.
Hi, thank you so much for having me. So I've got the advantage. It's 9 o'clock already in Munich and not 8 o'clock in the morning like it is for you. And I've got my first cup of coffee already behind me and my second cup in my hand, so we can start. I do have some conflicts of interest. I speak and get speakers' fees from a bunch of companies that make targeted and immune therapies. So I'm speaking to you today from Munich. I don't know if any of you have been to Munich. The nice thing about the hospital where I am is it's quite close to the old city of Munich, and some of you probably know Munich because of this here. The Oktoberfest takes place within earshot of my hospital, not today, but in October. And my hospital is positioned in this pink area near a park here, very close to the Oktoberfest and close to the center of the city. So if you do ever come to Munich and you want to come visit or exchange ideas directly, please do feel free. I'm in one of the oldest hospitals in Germany. It's this yellow building in the upper left, and beside it, they've recently opened a new hospital with state-of-the-art everything. So we've got sort of the best of both worlds. But we're here to talk today about BRAF targeted therapies. And I'd like to start us off with a case. And this kind of case doesn't this isn't a typical presentation of lung cancer, but certainly a presentation that we see all the time and that causes us challenges, namely people who present, as with this woman, with so much pulmonary tumor and respiratory distress that their initial presentation requires intensive care support. In this case, she was immediately on high flow oxygen. She was in respiratory distress. You can see her CO2 was at 28. So very difficult first presentation. And in that situation, one of the first questions we ask is, of course, do we think it's lung cancer? Or is it surely lung cancer? Can we do bronchoscopy, or can we get a diagnosis in some other way? And in this case, because she was so unstable in a respiratory way, we biopsied an axillary lymph node, seated under high flow oxygen on the intensive care unit, and got the diagnosis that way, and found within the first couple of days that it was non-small cell lung cancer, and then TTF1 positive adenocarcinoma, no PD-L1 expression. And immediately in a case like this, we can't wait for NGS testing. So we started with broad chemotherapy immediately and waited for NGS testing. And when NGS came back and we saw a BRAF mutation, a V600E mutation, which is relatively uncommon in lung cancer, we switched her therapy to the targeted option, to dabrafenib and trametinib, and the tumor responded very, very well. And it's a type of response that we're more used to seeing in EGFR and ALK mutated lung cancers. And to see this kind of response in a BRAF positive patient really solidifies what we know about BRAF, that it's a driver mutation. It's not a co-mutation or something that we sometimes find, but when it's present, it is often the driver of the lung cancer growth, and inhibiting it can be exceptionally precise and effective, as we saw with the patient I showed you. In this diagram, you can see the global differences in Western versus Asian populations, Asian being the outer circle with higher EGFR mutation load, and Western European populations, North American populations with a lower EGFR mutation load. Those are the red sections. And BRAF seems to be similar across the world, with around 1 to 2% of non-small cell lung cancer showing the V600E targetable driver mutation, regardless of geography and ethnicity. BRAF mutations are not only found in lung cancer, and they're actually more common in some other types of cancer, in melanoma and some colorectal cancers, where they account for between 4 and 8% of the tumors. There's a lot of the study data that is in drug development that goes on around BRAF is in the melanoma world, and the NSCLC world is sometimes a little bit behind them. So when we talk about BRAF mutations and the 1 to 2% that are these V600E mutations, we're only talking about a small subset of the BRAF mutations that exist in non-small cell lung cancer. And actually, there are three different classes of BRAF mutations, with our targetable V600E mutation being in the first class, and the second and third class are not targetable on label at the moment. There are drugs in development, and there are some compassionate use and individual patient programs going on in other parts of the world, none in Germany at the moment. I'm not sure if there are anywhere you are. But certainly we're expecting to see in the area of class 2 and class 3 BRAF mutations developments in the coming years. If we think about driver mutated lung cancer, often our mind jumps to EGFR and ALK, and we think of young, never smoking women with a predominance for Asian background and adenocarcinoma. And not all of those characteristics are true of BRAF mutated lung cancer. We do see a strong predominance for adenocarcinoma, but we don't see a clear association with younger age or female gender or with a specific ethnicity. We also see a lot of smokers, current and former smokers, within the group of patients with BRAF mutations, although there are also 20 to 30% never smokers. There's a high risk of brain metastasis and a high need for therapy. The approved combinations for the stage 4 setting are a combination of a BRAF inhibitor and a MEK inhibitor. So the pairs that are approved together are dabrafenib with the MEK inhibitor trametinib, or the BRAF inhibitor encorafenib with the MEK inhibitor binimetinib. And in terms of the history of BRAF therapies, dabrafenib trametinib was the first combination, and in Europe we've had the encorafenib binimetinib combination for the past couple of years. You can find the combinations in the guidelines. The NCCN guidelines recommend both combinations or give an option of a monotherapy with dabrafenib. And the ESMO guidelines include the dabrafenib trametinib combination. The version of the guidelines that I pulled to make this slide did not yet list the encorafenib binimetinib combination, I think because the diagram hadn't been updated yet. So I added that little green box to show you that there is European approval and has been since 2024 of the encorafenib binimetinib combination. Whenever we have more than one option, we start thinking about what we should pick. And so I'm going to show you the data for both. And at the end of it, you're going to see that they're fairly similar, and that the important thing is to think about BRAF, test for BRAF, and treat BRAF, but not, we don't have data comparing the different options directly. So if we look at the first combination that was approved and on the market, and here we're in the phase 2 studies, there were treatment naive and also previously treated patients who had received chemotherapy and immunotherapy previously. We see strong waterfall plots with lots of responses, some stable disease, some complete responses in both treatment naive and pretreated patients. And we see good progression-free survival in both groups, also in previously treated patients. And that's a little different than what we sometimes see, that, previously treated patients don't respond as well. So it makes us wonder whether BRAF has to be the first line treatment or whether we can use chemoimmune therapy in first line and then move on to BRAF. If we look at the same data for encorafenib plus binimetinib and the waterfall plots, they look very similar. There are a few patients who didn't respond at all, who went on to have strong progression, but most patients had tumor shrinkage, lots of stable disease and partial responses, and a few complete responses in both treatment naive patients complete responses predominantly in the treatment-naive patients, and some good responses in the previously treated patients as well. If we look here, we seem to see maybe a little bit of a stronger progression-free survival curve in the treatment-naive patients in this setting compared to in the previously treated patients, but both curves do show clinically relevant, very, very good durations of progression-free survival. It's always important, especially in the stage 4 setting, to keep safety at the front of our minds. And the safety profile of both combinations is quite manageable. There are a few grade 3 toxicities, but at low levels, some lab values to keep an eye on: anemia, neutropenia, some rash, some GI side effects, and some reported toxicities around fever, chills, and blood pressure changes. And if we look at the encorafenib binimetinib combination, also here very well manageable, quite similar as we would expect toxicity profile. Something that's reported in at a grade 1-2 level. It's a little unique to this setting is some blurred vision, but other than that, fairly similar to the toxicity profile of the first combination. So the encorafenib plus binimetinib data were updated recently with a data cut from the Pharos trial and published. And here you can see that I don't know if you can read it on your screen, I'll read it out for you, a PFS time at the last data cut of 30 months and a median overall survival of 47.6 months. So long duration of response, long overall survival, as we would expect, from our experience on other targeted therapies in stage 4 adenocarcinoma. So I mentioned that there are no randomized trials in the first-line setting comparing the BRAF therapies in lung cancer to chemotherapy plus checkpoint inhibitors. And so what a German group, I know most of the authors on this paper, did is a big registry study in Germany comparing patients who were treated with chemoimmune therapy despite having a BRAF mutation, a BRAF V600E mutation, or patients who were treated with dabrafenib tremelimumab. And you can see here that the curves are very, very, very similar. There's absolutely no difference here in what they describe as overall survival, depending on which treatment you choose as the first-line therapy. And so I think there's a lot of room for us here to decide based on patient preference and based on maybe based on smoking history and PD-L1 expression and all the other things that we look at when we try to predict response to chemoimmune therapy. There is another global registry study that looked at a similar level at retrospective comparison of first-line chemotherapy with checkpoint inhibition versus first-line BRAF-targeted therapy, and found, for instance, that women with lung cancer with the BRAF mutation have a better course if they start with the BRAF-targeted therapy, and the male patients, it didn't make such a difference. So definitely a bit of a gap in our high-level clinical evidence to inform our decision what to do in the first line, which leaves us a lot more room for shared decision making with patients and individual treatment decisions. So what do we do if we've started with the BRAF inhibitor and it's worked or it hasn't worked, and then the patient goes on to progression at a later point? So the first important point is, if we have started with a targeted therapy and the patient has not yet received chemoimmune therapy, then chemoimmune would be the next option. Of course, if we've started with chemoimmune therapy and we know that they have a BRAF mutation, then the BRAF therapies are the next option. We do, as in many settings, treat oligoprogression with local therapy. And I strongly believe that if we're going to treat oligoprogression with local therapy, we have to make sure that we're dealing with oligoprogression by doing more imaging than just CT of the chest. So that would, for me, include at least a CT of the abdomen and pelvis and an MRI of the brain. And at my setting in my center, I have very easy access to PET CT. So I often do, in situations of oligoprogression, do a PET CT. We also do rebiopsies if we can in this setting, although there isn't very much known about all of the mechanisms. There was recently a nice Nature Communications paper looking at the mechanisms of, I'm going to show it on this next page, of mechanisms of resistance to a novel BRAF class 2/3 inhibitor. And even with the class 1 BRAF MEK combinations that we have, we don't know extremely much about the resistance mechanisms, but we do like to do rebiopsies in case we do find something that we can target. And that brings me to the the outlook and the future treatment options for BRAF. And there certainly are class 2 and class 3 BRAF mutation inhibitors in development. And there is, I think in South Korea, an early access program which is limited to specific disease entities looking at a targeted therapy. And as far as I know, at least in Germany and in my part of the world, they're not available yet, but we've certainly got our eyes open. So in summary, BRAF mutated non-small cell lung cancer is rare but very relevant. We need to screen people, and that includes smokers, because they have just as many BRAF mutations, if not more, than non-smokers. We need to treat patients with the BRAF V600E mutation with a BRAF inhibitor and a MEK inhibitor combination. There are two similar combinations on the European market, which are listed here. We should test before first-line therapy, even though there's no very clear evidence on the best treatment sequence, whether it's better to start with the inhibitors or to start with chemoimmune therapy. At the end of the day, most patients should at some point receive both treatments. We do reassess at progression. We treat oligoprogression with local treatment, and we do a rebiopsy if we can. And we've got our eyes open for class 2 and class 3 BRAF mutations. Before I get into questions, I'd like to show you what happened to our patient from the beginning. So she had, after about a year of her BRAF-directed therapy, she was at home for that whole year. She did have a single site of progression in her lung, which we treated with a local therapy. And unfortunately, a few months later, she went on to have multifocal progression and was switched. Here you see the initial CTs at the time of her diffuse progression, switched to carboplatin, paclitaxel, and pembrolizumab, and did well on that therapy for a couple of years before going on again, unfortunately, once more to progression. So at that, I would like to close my part of the talk, and I hope you can join me for some questions and discussion.
Excellent. Thank you so much, Amanda, for an excellent presentation. Maybe I'm going to start by asking, in your center, do you do reflex testing for a panel of genetic mutations, or is it
Yep,
something that you request specifically for each patient?
yep. So we do reflex testing in two different ways at our center. We're part of the German National Network for Genomic Medicine in Lung Cancer, which is an initiative out of the University of Cologne. And that network did a good job negotiating with the different insurance providers in Germany to get funding for NGS testing using an Oncomine panel in all inoperable stage 3 and all stage 4 non-small cell lung cancer patients, and repeat testing at the time of progression on a targeted therapy. So at those times, we have financial coverage for the test, and we do it on all patients in a reflex um, manner. Our turnaround times are not as low, to be honest, as in some other centers that I've heard. We usually need at least 3 weeks to get a result back. And so in patients where we really need an answer more quickly, we will do individual PCR for EGFR and immunohistochemistry for ALK to exclude those before starting a first-line chemoimmune therapy if somebody has a high tumor burden. But we certainly do hope to get an NGS before starting treatment in most patients.
Excellent. I think we have a very similar experience in the UK. The UK reflex testing occurs throughout from biopsy onwards. So
Hmm.
from biopsy, early stage disease, all the way to advanced disease, and it takes around 3 weeks
Yep.
in general to get the results back. Got a question from Dr. Addy who's asking, in patients presenting to you, would the first line treatment, if you have a BRAF V600E, exclude chemo IO, or do you do chemo IO and save that as second line? How do you actually manage your patients?
Yep. So that's a really great question. And I mean, that's something that the data that we have from the big trials doesn't answer for us in this situation, right? I think most patients, if we know that they have the BRAF mutation when we're initiating treatment, I will give a BRAF targeted therapy too. I think most patients prefer to take a targeted oral therapy in comparison to a chemotherapy. There's, at least in my patient population, a lot of chemo aversion, which I think is very reasonable. Um, there are, I mean, the case that I showed was a little dramatic. Certainly not all of our patients start their lung cancer journey on the intensive care unit on high flow oxygen and can't lay down flat for a bronchoscopy. But we do have patients who are in a gray area who we say, we don't want to wait 3 weeks um, for the full testing, so we'll start them on a chemotherapy IO as soon as we've excluded EGFR and ALK. And if they start on it and we find a BRAF mutation after the first or the second cycle of chemo IO, then I tend to do a reevaluation with imaging and check how they're responding to the chemo IO. And if I see a good response, then I'll keep going with that. I mean, never change a winning team, right? Um, so I think it's definitely an individual decision.
Understand. You mentioned the concept of oligoprogression. Now,
Hmm.
local consolidation treatment is slowly gaining traction with the
Hmm.
clinical trials around the world. The
Hmm.
most probably biggest examples is with EGFR, the North
Yes.
Star, and you've got ALK with brigatinib on Bright Star at the MD Anderson. Now, would BRAF 600E targeted treatment fall within the confines of the possibility of local consolidation? You mentioned aggressive treatment for oligoprogression. Would that include surgery as well as radiotherapy? Is that what you practice in Munich?
Yeah, so we definitely I think the treatment of oligoprogression is always very individual, and it has to do for a lot of us, I think, with the time and the tolerability under the targeted therapy. So if somebody has an oligoprogression after 3 months of treatment, then that's certainly less of an indication for aggressive local therapy compared to somebody who has been responding for 18 months or 24 months and then they have an oligoprogression. Um, so if we have a course of response and duration of response that makes us really believe that we're not looking at the first of 100 metastases that are going to pop up, but a real oligoprogression, then I'm a big fan of aggressive local therapy, including surgery, especially because we know that lung cancer patients get other cancers. Right. And I mean, we certainly have all had the experience of surprise lung cancer diagnoses when somebody with a breast cancer goes for resection of a pulmonary metastasis and then it's a TTF1 positive adenocarcinoma of the lung, or um, an oligoprogression of a lung cancer that turns out to be another histology. The liver metastasis is from a GI tumor or something. So I do think that, especially with a long, stable interval under treatment, there's a good indication also for surgical treatment of oligoprogressing metastases.
Can I ask for your patients that you treat on follow-up, do you monitor or undertake surveillance using ctDNA looking for escape or when the BRAF V600E no longer becomes visible in the blood?
No. We always hear about it at the meetings, right? And we sort of think everyone does it. But it's not part of our routine practice. Um,
It's interesting because in the
uh,
UK, increasingly we're moving towards ctDNA, and that's
yeah,
also a nationally funded scheme at the moment. And
yeah,
I find that very, very interesting intersection. But as you mentioned, not many
yeah,
centers around the Europe or around the world outside of America is able
yeah,
to afford this. It's very expensive, I presume, as well in Germany.
right. And I mean, first of all, it's expensive, and secondly, we have very good access to imaging. And at the moment, the even our patients who respond very well to our treatments don't have a lifespan that I'm worried about them getting a lymphoma in 20 years caused by too many CT scans. I mean, I think at the moment we can be fairly liberal still with using imaging as follow-up. There are some settings where we can't, and we have to keep working on it. But in our hands at the moment, it's not our preferred way of doing follow-up and surveillance. We
Excellent.
do we do liquid biopsy as an alternative to tissue biopsy in patients who don't have readily accessible sites that we can biopsy.
And is that
Um,
nationally funded?
yes, so that's nationally funded through the same National Network for Genomic Medicine, but the network does have a strong preference at the moment for tissue biopsy, also because sometimes we still see, especially in like EGFR patients, a small cell transformation, or we see um, surprise histologies. So I don't think we're quite at the point yet where we, in patients who can undergo a repeat biopsy and who have a readily accessible site, where we would replace a tissue biopsy with a liquid.
Excellent. Thank you so much for your kind presentation today and great insights into this field. Next week, we're going to have Professor John Haymatch from MD Anderson talk to us about HER2 alterations and based on his recent publication in the New England Journal, which leads me once again to thank our sponsors, AstraZeneca, Medtronic, and Medela Science of Care. And once again, to you, Amanda, for leading the field in this area and for your excellent presentation today.
Thank you very much.
Thank you very much. Bye-bye.